Bruce mentioned about, and I presume it's from Manal, but actually Sam, in fact, anyone might want to do this, the role of public health and local authorities. Um, they say, and the spatial planning too, he says, oh, as a, ensuring that the volume of housing doesn't bake in poor health outcomes. So we've got this much wider part of health in which we talk about. Manal, can I come to you first of all? How are we talking to those MCLG and the local authorities and public health to make sure this does get sorted?
Yeah, absolutely at every single level. So at place level, local authority and public health are partners, key partners in the place partnership. Every single visit I've done, they're around the table. They're part of decision making strategically as well as supporting delivery. So yes, yes, yes. And then nationally, we're working across those government departments as well as working with, the local government association and wider groups that can support us. So it's very much wider than healthcare, and it's looking at health as a horizontal, and I can't emphasize that enough. And just to say, this doesn't work without those place partnerships. All of those partners bring different strengths, and the key to this is then distributing that leadership with each partner driving and leading where they hold the strengths to create the whole. So we're all greater than the sum of our parts, essentially.
Brilliant. Thanks. Um, I'm going to ask one for Sam, actually. Jill Warburton, you're mayor of your town, and you've got an overarching responsibility of health and well-being. So she's asking, how can we get the ICB and the volunteer groups around the table with primary care and everyone else who are stakeholders? So here is a non-health lead as the mayor trying to make things happen from a town, not from a combined authority. But Sam, in your kind of, and perhaps Gillian can come in as well, about how do you get those people together? You talk about trust, we talk about relationships. How do we do it? How would Jill do it? What would you give her advice to do?
So this comes down to relationships yet again, and the simple answer, and what we've done for years at Bromley by Bow, is just to get people round a round table. Actually, really important, uh, over food. It's what we do naturally in our private lives. It's no different, actually. It's about relationships and getting people around the table and not being presumptive before the meeting, okay, about what the outcomes will be. Find in the room the win-win scenarios. That's where you will have greatest success. But the other thing is you need to be confident, actually, about this whole concept of social prescribing. There is a mass of evidence now, actually, about how effective it is. It's not as easy, yes, as this pill will reduce this blood pressure, but the evidence is there. And for anyone who wants to, go to the National Academy of Social Prescribing and their booklet on the impact of social prescribing on health services use and costs. We need to be throwing out this evidence much more widely so that the system actually understands this is powerful medicine. In itself, it's powerful, but the challenge it gives to actually traditional medicine and some of the damage that traditional medicine causes is really important. Never forget that in over 65s, and I'm one of them, 10 to 20% of admissions to hospital are as a result of drug side effects. If you don't give doctors and GPs an alternative pathway, the left shift, the left shift, how can you not be surprised, actually, of the level of damage that can be done by traditional medicine? And don't get me wrong, we do brilliant biomedicine in our neighbourhood and brilliant social prescribing at the same time. It's entirely possible.
Thanks, Sam. That's really great. And Gillian, I want this one. This is about, and might also find Donna as well on this one. So thank you. Everyone's saying what an inspiring webinar. Everyone's saying please get the recordings. They all want to hear it more and send it on to people who weren't able to make it. So that shows the quality that we're hearing. But Shelley Oberg has mentioned, how do you convince healthcare practitioners that may have been working in the NHS for many, many years that this is the way to go? So Gillian, and I think this comes into another kind of wider thing, perhaps on leadership as well, of, there's some times that leadership can be a little bit behind the times. So Gillian, what's your experience?
Thank you. My approach has never been to convince anybody of anything, but to speak to people about what I believe in and what do they believe in, what are they interested in. Let's talk about the evidence and get people around a table with food, as Sam has said. That's exactly how we started, both as a community of health professionals in East Surrey and with head teachers, people from the council, charities, etc. So I've never tried to convince anybody, but what I found is that there are always so many people working in the NHS who believe in these things because, of course, we do have lives outside of work and we recognise that these things are important to us. So I believe that there are committed people to these values and these principles that we've discussed today in every single neighbourhood of the country, up and down the country. And I think what has enabled us to pursue this integrated approach in East Surrey has been two things. We've given protected time to one GP in each of our 5 neighbourhoods in East Surrey, and we specifically ask them to go outside of the 4 walls of their practice into the places where people are creating health and to listen and to support what is needed in their area. And we give them some investment to give to communities to support health creation also. Without that protected time, I think it's quite difficult often for very busy clinicians to have those meetings. So I think it's about protected time. And the reason that we were able to secure protected time for our GPs in all of our neighbourhoods was because we had incredible enabling leadership in NHS Surrey Heartlands from Professor Claire Fuller, who now is, of course, at NHS England, but also from other senior leaders, including Catherine Saunders, the Chief Exec of our GP Federation, and Shimona Chatterjee from the PLACE team in Surrey Heartlands. So they enabled us to create the conditions that were needed for neighbourhood health to flourish in our area. And perhaps I'll stop there.
Brilliant. Thanks very much. And I think I love that you don't convince, you just sit down and you have that relationship and you talk about what you're doing, and that enthusiasm is always infectious. If there's a vision, people want to be with that vision. They want to be part of it. But you have to make a bright, shining vision first, which is what you've clearly done. Donna, I'm going to do this one for you. And I think we haven't talked too much about carers. And obviously, they're an immense part of this whole program of neighborhood health. They're doing that work. And someone, they've anonymous who's put it in there. And they said, this is about people dying at home and carers helping volunteer carers and family carers, looking after those people who are from dying at home. And she's put here, it's as simple as they just want their salad cream for their sandwich, and that is a wish. And no, who's going to do that? And it's those small things. And she says it sounds petty, but it's so important when your quality of life is reduced to such a small area. And I think that's exactly what has been the problem. You talk about, making sure that we're actually going for the needs. It's what matters to the person rather than what the matter of it. How have you dealt, Donna, with carers, and how do the Chewies kind of encourage and support those carers?
Yeah, it's a very good question. So the community health workers will have relationships with residents. So those relationships will build over time, become more trusting, become more trusted. And so but also the community health workers have that 360 view of somebody's life and what's happening in their lives. And when there are situations around end of life situations like that, they are there to hold hands. They are there to listen, to do the things. They could easily go out and buy the salad cream or whatever that's needed. We give our community health workers in Cornwall an enabling fund, so they each have about £80 a month that they can use with low level bureaucracy to access it, but it is reported what it's used for well-being of their residents. So it could be that they go and buy the salad cream themselves for somebody, a birthday card, or something that helps that person, that resident, with their well-being. It's not a huge amount of money. I think the biggest item has been bought is probably up to £100, but it could be like 50p for a birthday card or some drawings, or I know a chess set was bought once. But it is having that compassion, isn't it, and that time. And our community workers have the time that no other profession in the NHS has. They can spend, as I say, universal proportionality. they spend as much time as they need with the resident. It could be an hour, it could be half a day. The basic they do is a monthly check-in, but they offer more if they need it. So I think that's the important part, is they've got the time to do that, and they spend that time if it's needed. So they'll support not only the resident, but the carer that's looking up, maybe looking after the resident as well, particularly if it's a family member.